Hi everybody, I'm Laurie Cadden, and we are here in the offices of Advanced Imaging Specialist in Dunmore, Pennsylvania, because we're going to do several shows on women's health and a couple shows on men's health. But today we're first here to speak about women, and more importantly, breast health. So we have two great guys who are going to talk a little bit about what you can expect when you come here for diagnostic testing, which they'll be able to tell you that. And they're just board certified, not to minimize that, doctor. They are board certified radiologists, and two great guys who will be able to tell you that. And more importantly, when you come in here, you're going to feel great because all of the people, from when you walk in the door to when you see one of these doctors or they read your slides, your mammogram, your digital now, it's all digital, correct? Anything that goes on with that, you'll feel good here. No matter what, they make you feel great. So today, through Electric City Television, we have our women's health program, and it is underwritten by Advanced Imaging, and it's a partnership between Mercy Health Partners and the leading community radiologists. So guys, let me tell you first who these wonderful guys are. Far over to my right is Dr. John Farrell. Doctor has been here just about 3 years. And then we have Dr. John, it's John squared, so I'm fine no matter what we do.
Correct.
See that? And
Very
Dr.
easy.
John Iannone, who is one of the founding members, and Doctor has been here since about 2003, started with about 12 other physicians, and going strong, getting bigger and bigger, huh?
Correct. Now, originally, I arrived in the area in 1996. That's when I came out of training and joined Radiologic Consultants Incorporated, RCI, and that's the company that employs all of our radiologists. And so some of us built this institution here back in '03, and you've been along with us for quite a while, right?
I love it. And I say that again. I don't just say it. When you walk through the doors, you have such fear just for whatever it is, because any testing is fearful, can be, for your own apprehension about what the results will be, what it's going to be like. Whenever I walk in, pulling up, it's just so pretty outside, you pull up, and then the people that you're greeted at the front desk, all the way through, from any of the experts who do the testing to you guys then coming back and reading them and sitting in that room and waiting for that to come. And not having to leave and be called. It's very personal.
Yeah, we're lucky that we have the front staff, the patient associates that we have up front, because they do put you at ease right initially when you are just fumbling for your insurance information or whatever.
Always, and that makes for a great business, because when you're the people up front, just like I say in any bank, it's the tellers, it's the people you meet all the time who make who you are better. So I'd like you also, if you don't mind, either one of you, and what we're going to do, folks, is just jump in here, because both doctors know a lot about what we're dealing with, obviously. So we're going to have just a little discussion on what it is and how everything works. But what else besides, obviously, we're talking breast health, what else can you get? What other type of testing, diagnostic testing takes place here, doctors?
Well, at Advanced Imaging, we have the full gamut of diagnostic procedures and some interventional type procedures, some procedures where we actually obtain samples of things, particularly from the thyroid gland. We do biopsies for nodules, and we can biopsy lymph nodes and what have you. But from a non-interventional perspective, we have the full range of MRI. And one of the things in MRI that we do that many other places don't do is dedicated cardiac MRI. So we can look at the heart. We can slow the computers can actually capture the heart in between and during its beating. And so we're able to specifically look at the heart anatomy very closely.
Is that, and correct me if I'm wrong, is that new? Is that more of a newer test?
It's been around for probably in private practice for about 3 to 4 years, I would say. And so we're doing that here. We do the full range from head to toe MRI, the same thing with CAT scan. And one of the things in CAT scan that we've been doing is the cardiac CTA, so to speak.
That's what I'm thinking.
A CT angiogram, and I guess Dr. Farrell can speak to that.
Yes, we do CTA, basically the whole body from the heart, which is a special CAT scan of the heart that requires the contrast, and we also do angiography of the aorta, the lower extremities, the upper extremities, the neck, and the intracranial circulation as well.
And all of this, we could go, I could sit here and ask a million questions on this because it is so, to me, it's just all so interesting. But, and again, I want you all to know what it is. There's so much that goes on here. Again, this is our first question.
You want me to keep going?
Yeah, no, my point is though, I want to jump into that heart stuff, but that's for our next,
Right, we'll do
our
that next
show.
time.
So we're talking
But
about, go ahead, yeah,
Again, we do the
finish.
X-ray.
Yeah.
We do the ultrasound. We do the mammography, which we're going to talk about. We do nuclear medicine, where you inject the radionuclide, we call it, in
Okay.
the arm, and we can look at various organs in your body. Pretty much whatever we do, DEXA scans for the bone density. So pretty much whatever your doctor would order for a diagnostic test, we can
You can
perform
do it.
here.
See that? Amazing. Amazing, these doctors. It just, to me, is amazing just what you can do in today's
It
world.
is.
It's amazing.
It is.
Technology is great. So, Dr. Iannone, I'm going to ask you the first question, although please, Dr. Farrell, feel free to jump in. Let's just have a little round table or rectangular table discussion. What is mammogram? What is a mammogram, and how often should a woman have one?
All right. Mammogram is a fancy word for a breast X-ray. And just like we X-ray your chest to look for pneumonia, we X-ray the breast to look for any changes that we can see that might be indicative of cancer. That's the bottom line, number one reason why we're doing screening mammography, which, again, a screening test is a test that you perform in people who don't complain of a problem.
Okay.
So a screening test is a test where you feel that the benefit outweighs the cost of doing that test in as many people in the population as possible.
Okay, and what types of mammograms are there?
Essentially, there are two main types based on how the test is done. One of them is a digital mammogram, and the other is a conventional film screen mammogram.
And so with the conventional versus the digital, obviously, the digital is can you see better? What is the difference as far as if someone said to you, doctor, I don't know if I should have, or is it up to the doctor to decide, the insurance company, the patient? How do you make that determination?
The general trend in radiology is that digital mammography is going to be replacing the old style film screen mammography, and that's
Okay.
occurring slowly across the country.
Okay.
The digital mammogram is, from the patient perspective, from the woman's perspective, if you've been having film screen mammograms all your life and now you have a digital, the differences will be subtle.
Okay.
The thing that you'll probably notice the most is that things happen quicker, meaning that you'll be in the views, in between views, when the machine changes position, that will be quicker than it used to be. And the technologist will be looking on a computer screen rather than having to leave the room and develop the actual film and then show that to the radiologist.
Okay.
So it's really a speed issue. The images are taken quicker, you don't have to develop film, and the radiologist can read them on a TV screen immediately.
So then when you would go to another doctor or whatever after you had this done, it's not, oh, come and pick up your films like the old way. It would be, can that just be technically, how does that get then transported to your other physician? With like an email
disc.
or something? Oh, it's right on a disc, so you just come in and take that.
The films can be printed as well, though.
Yeah.
Either way
Correct.
can be done.
And your doctor's office, in many cases, and that's the case here at Advanced Imaging, they can actually log on with a special password from the web and actually view the images from online.
Amazing.
So it can be an instantaneous type of thing.
Can both, say you recommend a surgeon after someone has this test, can both of you be looking at that at the same time?
Yes.
And having those type of conversations, so are you seeing what I'm seeing kind of thing, and that makes it
Exactly, yeah.
easier,
So
right?
You can conference on the telephone, and both be looking at the images, someone remotely, and me here at the center, and discussing the case. And that goes for not only mammography, but every other modality that we provide here. Our referring physicians have access electronically to all of the studies, so that they can see the images themselves and discuss with us the findings.
Yeah, it's amazing. Again, it's all amazing. So tell me, a woman comes in for a mammogram, her first mammogram. And let me tell you guys, speaking because I'm a woman, because I've had this done now for the last 8 years, I can tell you that it never feels the same, it never is the same, your apprehension levels are different. So when a woman comes in just brand new off the street who says, I'm here for my very first mammogram, what do you tell her? What can she expect when she goes back in and meets with Annette and she's all ready to go? What would she expect to happen to her?
Well, first of all, the current recommendations for a screening mammogram by the American Cancer Society are women who are 40 and above should receive a mammogram every year. Now, the situation is a little bit different if a woman has a family history of cancer at a young age. Say, for example, a sister was diagnosed at age 42. That patient should be screened 10 years prior to when her relative was diagnosed. So the 40 guideline is fine for women with no strong family history. But if there is a history of a family member diagnosed at a young age, then the screening should begin well before the age that family member was diagnosed. As far as coming for the mammogram, I mean, anxiety is normal for any type of diagnostic imaging test. Some patients experience more than others. But what I say to patients who are experiencing any level of anxiety is that the hardest part is showing up. When you walk through the door of the imaging center, you're halfway there.
Right.
And it's my job and John's job and the other doctors who work here, it's our jobs and the technologists' jobs and the staff's, it's our jobs to get you through the other 50%. To get you through the test. And my feeling, our experience is that, in many cases we can relieve, not all, but most of the anxiety that patients have, especially with mammograms, because there's a lot of anxiety, and rightly so, associated with breast health and breast cancer.
So I like to just, if you don't mind, I think what's also good is when you come in and then you go back and you put the little pink little cape on and you go into the room, sit, talk to Annette, talk to her. She does the whole test, and then you're sitting there. Now you don't have to when the doctor, after you look at the actual images, thank you. You would go in, if everything's okay, you don't even have to, she comes in and says, hey, you're cool for another year, good, no problem. That's what happens on it's not like you have to say, oh, I have to sit with the doctor now, I have to do, barring any, problems.
It's your option.
Exactly. So you can do that if you wanted to.
If you come in and you want to speak to a doctor, that can happen.
Okay.
I mean, we're there, we're on site.
Exactly.
But if you're fine with Annette giving you the information, then that's fine as well.
Yeah, well.
The key is, though, is that you don't leave, as a woman, and a patient here, you don't leave without knowing whether your mammogram is clean, or whether you need additional views, or whether you need another test, again, to answer that question, is there a cancer there?
Right. So that leads up to the next question then. What conditions then, as you said, you're screening, you're looking for any form of cancer. What else can a mammogram reveal? What conditions also, beside that, can they reveal?
Well, very quickly, I mean, the breast is, if you boil it down, it's a modified sweat gland. I mean, that's the basic thing. So it secretes liquids, it can grow hair, it does all the things that other parts of our skin do.
Right.
So you can have cysts. It's very common. You can have little benign tumors that are called fibroadenoma. They're just little benign. They can be very small or they can be very large, and you can feel them as a lump. And there are infectious or inflammatory conditions of the breast. Just like we can get pimples anywhere else, you can get that in a breast as well. You can have trauma the fat in the breast can actually become inflamed and scar down, and that could feel like a lump.
Like a hematoma or something that would develop based on some bump or bruise or whatever.
So, I mean, the vast majority of things that we chase with mammograms, and we do the ultrasounds and things, the vast majority of things are benign.
Okay.
But again, we're here to diagnose that more serious condition.
Right. Now, when a woman comes through the door, again, and I keep saying woman because I know it's primarily women's health, but men do have mammograms. So
true.
I don't mean to exclude the men when I say this, but by and large, it is the women are coming through the door. And As I told you, the first time I would come in and I would do, you sit there and you're waiting. And my being who I am, I sit there after Annette does everything, and I sit there in the chair, and I'm my own anxiety, as you were saying earlier, and I'm like, please let everything, please, talking to myself, okay, it's going to be okay. And then she comes in. And so while she's gone, I have this, because I think anybody does, it's that fear. So your fear of the unknown, because like I said, no matter what happens for that year, you come back every year, you better come back every year, because things can change radically in a year. Okay. And so it is so important to be here and for your own health. But so when she would come back in and Annette will go, you're fine, I start crying again out of the fact that now I'm so joyful that this is all okay. And I literally skip into that room and I get changed and I go out and I'm like, yes. And the girls are all, when you walk out there, they all know how happy you are. So how do you tell somebody? What's the best way for us to tell people who might be watching? I have to do this. I'm turning 40. I have no history, no family history. So my doctor's telling me, okay, you're going to be 40 years old. You have to get a baseline. Is it still considered a baseline? Is that correct terminology? Yep. Mammogram. Let's see what happens. And they are scared to death of what it might reveal or what. How do you alleviate that?
Well, that's exactly what you just said is the crux of the matter.
Fear.
It's the fear of cancer.
Right.
That really, when you boil it down, it's, is my life going to be changed because I got the mammogram? So the mindset that you have to change is that the mammogram is going to cause me cancer because it's going to find it.
Yeah.
You see what I'm saying? So
right.
That's a human trait, is that what we don't find doesn't exist. And so I think one of the best things for women who really, and for men for that matter, who continually put off their routine medical care because they feel fine and because they don't want to deal with the consequences of having something serious, they need to have a buddy system and treat the test as if they're going out for a fun day. So I think we've had some good
parties.
Well,
it's called a mammogram. I mean, I've had friends
right.
who
you
they
all
would all
get
make
together,
their appointment at the same time,
and you go have some fun. You have a nice lunch
Yes.
afterwards, and you support each other.
Yes.
Rather than doing it, if you can't do it alone, then do it as a group.
So if you had to say to somebody, again, you're saying do it, and I'm saying it's for your own health. Do it because you need to do it, and it's so much better to know what about your body than not. So, doctor, if you could say one thing about how do you get a little bit beyond that fear? What do you think the difference is to someone who comes to advanced imaging and says, I'm here for my first mammogram and I'm scared to death?
Well, I mean, as I said before, you're here, you're scared, but you're here.
Right.
So, we can get you through the rest of it. There's a lot of fear, and rightly so, regarding breast cancer and other breast disease, not just breast cancer, but obviously breast cancer is the foremost. But as John said before, it's a screening test, meaning that everyone in the population, when they reach a certain age, needs that test. And the best way to preserve your long-term health is to just grit your teeth and get it done. And we'll make it as pleasant as possible. And also, oftentimes when we check your mammogram, we're checking it on site when you're having it done. In many cases, we do what we call additional views. We see something, and the breast, each woman's breast tissue, the fibroglandular pattern, as we call it, the makeup of the tissue, which is basically glandular tissue mixed with fat. Every woman's is different. It's almost like a fingerprint. So sometimes we do a screening mammogram and we see something that looks a little different, or we see something that's a little asymmetric, and we get additional views. So that in itself provokes a lot of anxiety, because the mammographer will come back into the room and say, okay, we need to do an additional view of the left breast or the right breast or both. And this is a very common thing. What the additional views allow us to do is focus on a certain area. It allows us to put more compression on a certain area to spread out the tissues better. And in most cases, when we do additional views, it's fine. We further investigate an area that we questioned. The additional view answers our question, and the mammogram is normal. So it's the benefit of having the doctor look at it on site is that sometimes if you go for a mammogram at another place, the mammogram is read later that day. They say, oh, the patient needs to come back for an additional view. You get a letter saying that something was abnormal. you have to come back, you make an appointment, and a week goes by, and you're wondering what could be wrong with my breast. When you come here, we take care of it in one shot.
And that's, again, just speaking about to the differences between digital and film screen mammography, one of the things that digital has done is reduced or decreased the amount of additional views you need for calcification. The digital technique shows calcification better than the old film screen technique.
And calcification, while we're on that, because that was going to be my next question. Calcification, do most women have calcification? Or is it, because from what I know, and again, I'm not the expert, but from what I read and what I try to understand about it is that yes, in fact, that happens. And that, so is that something, say someone comes in regularly, they have calcifications, is that always then monitored to see that there's no change? Is that what happens then when you get these additional tests? Anything that's in there is then monitored?
Well, there's a spectrum of calcifications. There are calcifications that are benign in appearance, and many women have calcifications like this in one or both breasts. Calcifications like that, they don't need to be followed because just by their appearance, their shape, their number, we know that they're benign. Okay. They're not a worry. Now, on the other end of the spectrum, there are calcifications that are very suspicious, so-called microcalcifications. Those calcifications are always biopsied, okay, because of their suspicious appearance. And then there's a gray area. There's calcifications that we cannot tell for sure on the mammogram if they are benign or malignant. They also get biopsied because we can't tell for sure on the mammogram. Now, sometimes we'll do a follow-up mammogram if we see new calcifications that have developed since the patient's previous mammogram, but the calcifications don't look suspicious and they don't even look indeterminate, but they're new. Sometimes we'll do a short interval follow-up examination in 6 months just to make sure that nothing is developing there.
Okay. So what about then a breast MRI, and I want to make sure I'm getting this, and an MRI-guided biopsy, which you're just getting into biopsies. Tell everybody what they are.
Okay. Well, a breast MRI is an MRI examination of the breast that's performed with the contrast agent, which is a gadolinium-based contrast agent. And it is a test that is used as an adjunct to mammography. It's a very popular test because it has a very high sensitivity for detecting breast cancers. Okay. Now, currently there are recommendations for who needs to get a breast MRI, just like there are recommendations for a mammogram. Currently, the American Cancer Society recommends that anyone with the so-called breast cancer gene, the BRCA1 or the BRCA2 gene, should be screened yearly with a breast MRI examination, in addition to mammography. It's an important point that breast MRI never replaces a mammogram.
Okay, that was going to be my next question.
And the reason is because these calcifications, microcalcifications that can be a sign of early cancer, will not show up on a breast MRI, okay? But they will show up on a mammogram, okay? So breast MRI never replaces a mammogram. It's always used as a supplement or as an adjunct to a mammogram. So anyone with the BRCA1 or 2 gene tests positive, who has tested positive for that gene, is a candidate for a yearly screening breast MRI. In addition, any primary relative of someone who has tested positive for BRCA1 or BRCA2 is a candidate. So a mother, a daughter, sibling, even if that person themselves has not been tested for BRCA1, as long as they have a primary relative who has tested positive, they too are a candidate. Women who have received radiation therapy to the chest as a child, adolescent, or young adult for lymphoma,
okay,
they are at higher risk for breast carcinoma, and they should get screened annually with a breast MRI in addition to mammography. And finally, there are several methods to calculate a lifetime risk of breast carcinoma using your age, number of family members with breast cancer, and many other factors. And these models that are out there will calculate a lifetime risk of developing breast carcinoma. Okay? If your lifetime risk is 20% or greater, you are a candidate for a yearly screening breast MRI in addition to mammography.
Now, getting to the 40-year-old with no, as you were saying, if you had no family history, and why is the year 40? Why is that significant to women in getting any of these procedures to the breast?
Well, like many cancers, the incidence of developing a cancer goes up as one ages. So the age of 40 was chosen by the American Cancer Society because it's the perfect time, because hopefully we can catch most cancers early, and if we start screening women at age 40. And the other issue is younger women have very dense breasts,
Yep.
and the mammogram, as a result, is very limited in patients with dense breasts. Okay, so women in their 20s and 30s who have very dense breasts, the mammograms are very limited. Women who are in their 40s or older, the breast density tends to lessen somewhat. The other advantage of digital mammography, however, is that there is better tissue resolution, which means we can penetrate the dense breast tissue better with the digital mammogram than the so-called analog or film screen mammogram.
So to answer that question, it's a statistical answer.
Okay.
So 40 was chosen because looking in the past at cancer rates and the epidemiology of breast cancer, 40 seemed to be a good fit for a screening test, which is something that, again, like we're saying, is going to be done to everyone ideally.
What I always found fascinating with these tests, and then looking at the actual film, because of course when I would take one to a doctor, I would always look at them, just not that I knew what the heck I was looking at, but I would hold it up and say, what am I looking at here? But how that your breast is actually compressed with the machine, and then how it looks like it looks like the shape of your breast when you're looking at it sideways. I could never
Interesting.
understand.
Isn't it?
Do you know what I mean? You're seeing it the way it looks, but it's compressed for the testing. It's amazing.
That's I mean, for the women who are going to be watching this on TV who are contemplating having a mammogram, have never
right.
had it, your breast is going to be squeezed, as you know,
Yeah, squeezed.
between two cold metal plates, so to speak, and that is the way it is pretty much everywhere. I mean,
Yeah.
that you can't get around that.
So you can't put any kind of like velvet warm lining or anything on those things, right?
Well, they may be working on that. Now, on the breast MRI piece, it's a completely different animal.
Okay, and why? And what is how? What do they expect with that? What would be the expectation, or what happens when someone would have that done?
A breast MRI examination is performed with a patient laying on their belly.
Okay.
And the breasts are situated in what we call a breast coil. Basically, it's two cups, somewhat like a bra, that the breasts will be in for the entire examination. So the patient, as long as the patient is comfortable on their stomach for about 20 to 25 minutes, that's really all that is required for the breast MRI. There's no compression whatsoever involved with the breast MRI examination.
Oh,
Except for the biopsy procedure, where there was
Right,
a little
that's-
Biopsy
difference.
procedure, involves some compression, but a regular diagnostic breast MRI examination involves no compression at all.
There you go.
see, so some of it's less. Than that
That's
at
right. They're
that
just
point.
you're just lying, put your face down, unfortunately.
Mm-hmm.
But you can tilt your head and be comfortable in an MRI.
And listen to music.
That's right.
See that? And it takes about 20-25 minutes.
About 20-25 minutes for.
And again, even the regular good old come in and get a mammogram. That is not a lot of time. It doesn't take up
Correct.
much of your time. You come in, and one thing I'll say, when you come here, you get right in. I have never waited. Maybe it's because I'm a little late all the time, doctor. But no, honest to God, they're always on
you're
time.
fashionably late.
I'm fashionably late. I'm within that 15 minutes, although someone might say, yeah, right, we're
And
talking
it's
more.
important to know with breast MR too that it's becoming the standard to, when a breast MRI is performed, to always scan both breasts. So if a patient comes in with an abnormality in, say, the left breast, we always scan both breasts. The reason for that is because symmetry is important in the breast. Sometimes subtle abnormalities can be detected by comparing one breast to the other, just like a mammogram. And oftentimes, we are able to detect an abnormality in the other breast, the asymptomatic breast, that was not on a mammogram, that the patient can't feel on a breast MR. So at advanced imaging, both breasts are always scanned, even if the patient is just coming in with a problem in one breast.
Right.
That's smart.
And it's the same for regardless of what you're doing within a breast MRI. Both breasts are going to get imaged
Okay.
anyway. So
Do it. Now, what else? Is there anything else you may want to say that I didn't bring up, or any other question or information about breast health that or services here that we can talk about before we wrap up for this first Women's Health
Well,
show?
since we were talking about breast MRI, that usually leads into a discussion about breast MRI biopsy.
Okay.
Sometimes a breast MRI biopsy is required. It is required in situations where an abnormality is detected on a breast MRI that we cannot detect on a mammogram and that we cannot detect on a breast ultrasound. Often breast ultrasound is used as an adjunct to mammography when an abnormality is detected, such as a mass. We will do what's called a targeted ultrasound of the breast to try to identify a mass that is seen on the mammogram. And if a patient has a breast MRI and we detect something that is, how we say, a occult on a mammogram or an ultrasound, then we have to biopsy it under MR guidance because there is no other way to get to this abnormality. And these abnormalities that are biopsied under MR are also usually not able to be felt by the patients, because if there is an abnormality that the patient is feeling or that a doctor can feel, that can be taken out surgically, of course. So the lesions that are biopsied by a breast MRI are those that can't be seen or detected by any other modality or physical examination.
And the other thing is too, which because what happens with these conversations is you roll into the next question naturally, which is good. So what I didn't touch on, which I think is important, and I think people need to know that upon a regular mammogram and there is some type of you're in some way, shape, or form want to go with a further test, they can automatically then be brought right in then and have an ultrasound after that, after you review the film and see what's going on. Even for another opinion, an ultrasound then would be performed on the breast.
Ultrasound is quick, painless, can be done at the time of your visit, and it's a great test for determining cyst or solid.
Right.
The mammogram, unfortunately, doesn't really tell us whether something is solid or full of fluid, which like a cyst, they'll both look similar. So the ultrasound, you put the little transducer on the breast, and right away we know whether it's solid or cyst. From there, we can even go as far on ultrasound as to say, is there what's called architectural distortion, meaning that when you're scanning the breast, the tissue looks similar from inch to inch, but occasionally you'll get an area that's different, and so that's something that has to be worked up further.
Because that's the first year, that's what happened. I went right from the mammogram and right in and had the ultrasound done, and of course it was fine. But my point is, it was whatever it was, whether it's concern, you checked
That's
out,
right.
everything was right here under this roof, and you were able to do that and have your answer.
Whatever it takes.
Yeah.
And we're pretty frank and honest about what we're doing.
Yep.
I think it might have been in the old days of medicine, the C word, cancer, was something that really wasn't freely discussed between doctor and patient. But it's not a mystery as to why a woman is here getting her ultrasound and her mammogram or her breast MRI.
Right.
We're doing that again to find something that's serious but that we can treat early. And that's the other key, is that a cancer diagnosis, if we find something in your breast, is not a death sentence. I mean, that's what a lot of women are very fearful, that they're going to go down the path of decline, and that's not the case at all. Matter of fact, the sooner you get your mammogram and the more adherent you are to the standards,
Right.
the better shot we have of curing it.
Right, because that's the beauty of it. Coming here, having the yearly, if you're lucky and that's what you get, and you come back in a year, we'll see you, great. You know what the breast looks like. Doctors they see it, they're used to it, they know, reading it, they have that knowledge. So then if there does something pop up and a year later, or however long, it would be a year, because you're here every year. Right. It's easier to help you then, because it's less time and you've had it clean all the way through, and
Night and
that's
day.
And that's why it's important to always, no matter where you go for your mammogram, always bring your old studies with you. Because
So important.
yes.
comparing from year to year, subtle changes can be detected when a current mammogram is compared to previous studies. So no matter where you go, or if you change facilities where you're having your mammograms, it's so important to come armed with your old mammogram so that they can
So
be
important.
compared.
The worst thing from a radiologist's perspective, from my perspective, is when a woman has been to 5 different places, doesn't remember where they are, and doesn't have any priors from all of these places. That means then that we have to now go on the hunt and just, where did you live last? Where were you? And that can be the difference between us detecting a change and something very small going by the wayside until it gets a little bigger.
Right. So that was our first series on breast health, women's breast health. And if you're a man and you have issues and you need to come and see them, please do that as well. We are going to have several more, 3 more on women's health. We're going to have heart, bone, and menopause. And then we're going to do a men. We're not leaving you guys out. We're going to do a men's health series, all televised here by the wonderful Electric City TV. And again, underwritten by Advanced Imaging Specialists. We're going to do heart health, prostate health, and early cancer detection. So we're going to talk a little bit about all those things that affect men.
Fantastic.
So I'd like to thank Dr. Farrell and Dr. Iannone for your time today. Thanks for watching, everybody. I'm Laurie Catton.